vai nos falar, falar sobre diabetes monogênico. Esse intramuros é da unidade de genética, só para deixar isso claro. Eu mandei um e-mail ontem esclarecendo, houve um engano na hora que foi repassado o novo tema, mas eu gostaria de deixar bem claro que é da unidade de genética, tá bom? Milena, a palavra é toda sua para introduzir o speaker.
Obrigada, Luciane. So, good
Espera aí só um
morning,
pouquinho.
everyone. Oi.
Hã? Ok. Okay. Okay, go ahead and thank
Okay.
you.
So, good morning, everyone. I'm very honored to present Professor Hattersley. He's a clinical scientist, a diabetologist from Exeter, UK. And the most special thing is he loves his job. He just makes sure that I share that with everyone. You will see all this love in his presentation. So I just like to share with you a few words about Professor Hattersley. So since we began our monogenic diabetes clinic in 2011 in University of São Paulo, all the publications from Exeter group have been like a great inspiration for great value for us for establishing our service here. But so only 7 years later, in 2018, I had the opportunity to actually go to Exeter and be part to attend the monogenic diabetes training course with all the Exeter team with the leadership of Professor Hattersley. It was an incredible experience. And we could feel all the love and the passion of the group. And I can tell you, Professor, we have the same feeling here with Professor Berenice Mendonca and Ana Claudia Latronic, our head professors. So I related a lot to your team. And since then, I was very fortunate to, encounter Professor Hattersley a number of meetings. And we are part of the MDAP, Monogenic Diabetes Expert Panel. And we monthly gather to do the correction of variants in monogenic diabetes. So I'm very, very grateful. He always have been so cordial, available, attentive, and with people to spread the word about monogenic diabetes. So Professor, thank you very much for accepting our invitation. And it's on you now. Thank you.
Thank you very much. It's a real pleasure to be talking to you. And yeah, so I hope I can share some of my pleasure and joy of working in Exeter and how we've moved on from genetics. So really what we're talking about here is precision diabetes. And what that means is instead of giving everybody with a clinical condition the same treatment based on clinical features or clinical testing, that you're going to give some of them different treatments to others. And I think what I want to do in my talk is really talk about the common monogenic form of maturity onset diabetes of the young, the familial type, and then move on briefly to neonatal diabetes, where children are born with diabetes, and really talk about the precision medicine and precision diabetes in those situations, and really ask the question, what about type 2 diabetes? Because clearly that's the big one, and we realize our patients are different, but can we start to use similar approaches that we've used in MODI? So where I'd like to start is with this family, and I quite often refer to something called found science, which is when you find something that you didn't mean to find. And this is a case of that. Robert Tattersall was doing a study on this family, and actually it was just one family member who told him that she had diabetes, but she quite often in the winter would have the winter off and not take her insulin for 3 months in the winter. And instead of berating her, he listened to her, and she said, and there's lots of other people in my family, and we can all stop our insulin in the winter. Now, clearly, that meant they didn't have type 1 diabetes. And when Robert went to the family, what he found, if you'd been at this wedding, was that the bride had been diagnosed with diabetes at 13, the mother at 17, the grandmother at 23, the bride's mother's cousin at 12, and then the two bridesmaids who were second cousins to the bride. Then neither of them had diabetes when this photograph was taken, but both of them had developed it by the age of 9. So what Robert described was these people had a young onset of diabetes, which was not insulin dependent. So although they were slim and thought to have type 1 diabetes, that was not the case. And he really identified that this was due to a single dominant gene, and also showed that it altered people's beta cell function. And for a long time, these families there were a few of them described throughout the world, but they were very small in number. But it started to be realized that some of the families with this type of diabetes were different from others. This family, for instance, they seemed to have a lower blood glucose, not as severe as the one in the wedding picture. And this was the very first family I met in Oxford when I started working there in 1989. And really the question was, were these families just different variations of one condition? Or were they different diseases? And so really, if you have a genetic condition, you can ask that question: do they have one gene with different mutations that causes the difference, or do they have different genes? And so the big step was to try and find the genes in these families, because then we'd be able to understand whether the differences that existed in the clinical presentation. And indeed, that happened, and it was a very long time ago. I have got very few pictures of me from those days, but in glucokinase, it was Philippe Fragel, rapidly followed by ourselves in Oxford, who described that gene, and then Graham Bell did fantastic work to identify HNF1 alpha and HNF4 alpha in 1996. And these were seen as important at the time because they were the first diabetes genes to be found. They were also the major causes of MODY. But really, as a clinician involved in the genetic discovery, I always wanted to go back to what were the patients like. And really, one of the very early things we saw was that their blood glucoses differed, their progression of their blood glucose differed. So the key thing was that the glucokinase patients, shown here in green, they had a raised blood glucose at birth, and then it remained raised at a similar level throughout life, deteriorating just at the rate that we see in the normal blood sugar. In contrast, the transcription factors started off with a normal blood glucose, and then that started to deteriorate with time. And untreated, the blood glucose would just progressively deteriorate over time. So we had genetic differences. They all had a beta cell defect, but those beta cell defects were behaving differently. And so we could start to move from just saying what the genes were to saying what the clinical features that went with it. Was it a stable, mild hyperglycemia, or was it a progressive, more severe hyperglycemia seen in 1 alpha and 4 alpha? And then to our surprise, in HNF1 beta, we found there was a very strong renal phenotype, with almost all the patients having a developmental kidney disease, often with renal cysts. But actually the histology was very different. So the genetic classification was crossing different histological classifications. And so really now it was worth finding the genetic cause, because it would help you define the clinical, the hyperglycemia and the other clinical features. But really the important thing for people is treatment. And really, I think the reason that this has reached the popularity it did was because we found that it altered treatment. some of the first things we found with the glucokinase patients was even the people who'd had no treatment throughout their life had just had this mild high blood sugar, that what we found was they really didn't have complications. There was a very occasional microaneurysm, but at a level that was also found in the control population, and no sight-threatening retinopathy, despite these patients in this study all had high blood sugar for at least 50 years without treatment. And so this was really saying that at least for the glucokinase, these were patients where treatment wasn't needed because they were not at risk of microvascular complications. And this was in marked contrast to type 2 diabetes patients diagnosed young, who had a very severe degree of sight-threatening retinopathy, including maculopathy and proliferative retinopathy requiring laser therapy. So this was a key difference, but that's actually reflected the glucose. So the need for treatment was different. What about the response for treatment? And this was really interesting because what we found was that when we looked at the first 800 patients we'd got, there was no difference in the mean HbA1c of 6.3% in those on no treatment and those on either a tablet, typically metformin or a sulfonylurea, or typically low-dose insulin. They all had the same HbA1c, and it was, so the big question was, well, was this because the treatment wasn't altering the HbA1c, or was it that they'd had a higher HbA1c and it was now well controlled? And what we decided to do was to take those patients who were on treatment, either tablets or insulin, and stop it. And we had 16 of these, and the HbA1c went from 6.3% to 6.3% off treatment. And so these actually are patients where treatment makes no difference. And that's because they've got a regulated blood glucose. They've got a glucose that keeps returning to the same fasting level, in the same way as someone who doesn't have diabetes. If you give them any treatment, they will still come back to their normal fasting glucose. And that's what we were seeing here. So that was the glucokinase. The commonest group, at least in our clinics, was HNF1 alpha mutation. And this really shows when genetics starts to come in with clinical findings. This was a patient who, one of the first patients that we diagnosed with HNF1 alpha. And that patient, 11 years after diagnosis, came into my diabetes clinic at the point that you see this first arrow. And he was 30, he'd been diagnosed at 25, he was now 36, and he was worried that his weight had gone up a couple of kilograms since we last saw him. And so that was the main thing he wanted to discuss. I was delighted because his HbA1c was excellent at 6%, and he was having no hypos. So he's on a low dose of glibenclamide. And because in type 2 diabetes, I knew that the effect of metformin and sulfonylureas was approximately the same, then I thought, well, we can swap him over to metformin. And I was quite proud of myself because I thought I was doing evidence-based medicine. But what happened after that was that his HbA1c over the next couple of years just continued to rise. And this was despite the metformin dose getting larger and larger. So he is now on a maximum metformin dose 2 years later with an HbA1c that had been around 6%, which was now over 10%. At this point, we did the simple thing of let's stop the metformin and go back to 5 milligrams of glibenclamide, or glyburide, as it would be called in America. And what that resulted in was a 5% drop, or greater than 5% drop, in the HbA1c in a 3-month period. And so that was far more than we typically see in type 2 diabetes. So that suggested that these patients were very sensitive to sulfonylureas. And we then went out to the other patients in the clinic and talked to them. And in lots of cases, we found evidence that they'd been the same. When they started sulfonylureas, they might have problems with hypos if they had them in normal doses, or they had problems with very high blood glucoses when they were stopped. And so this really was giving an idea that maybe all HNF1 alpha patients were very responsive to sulfonylureas. But the problem with this was, although we published it, it had no impact because this was just case reports, the lowest evidence of clinical evidence. So what we did after that was, and you and Pearson got the funding to do a proper randomized crossover trial, giving patients first sulfonylureas and then metformin, or if they were randomized the other way, first metformin and then sulfonylureas. And we did this for a group of HNF1 alpha patients and also a group of type 2 patients. And you can see the type 2 patients change in fasting blood glucose in the blue. And that was a very similar change in fasting blood glucose. So the sulfonylurea was similar in effect to the metformin. But in contrast, in the HNF1 alpha MODY, the impact of the sulfonylurea, in this case gliclazide, was 5 times greater than the effect of metformin. And that information that they were so sensitive to sulfonylureas meant that we knew they needed to be on very low doses. But we also knew that patients that had previously been controlled on insulin, often because they were thought to have type 1 diabetes, once this diagnosis was made, could come off insulin and be well controlled with a sulfonylurea. And so really, this is exactly the reason to do genetic testing, because now you're not only saying what are the best clinical features, but you're also defining whether they need treatment, and if they do take treatment, which is the best treatment for them. And so the HNF1 alpha and the HNF4 alpha were very sulfonylurea sensitive. The HNF1 betas were not, and they had a problem with making beta cells, and so they needed insulin. And so really, this was the reason that genetic testing spread in the UK, but also spread around the world, because now there was a really good reason for patient care for doing it. It wasn't just of academic interest. So really what we've done here is use a form of precision medicine where we've taken a broad clinical category, in this case, maturity onset diabetes of the young, subdivided it into different types, in this case by genetics, and then those genetic etiologies are leading to different clinical courses and different treatments. And that's a very common model of precision medicine. As you will hear, it's not the only one, but it's one where you're subdividing the disease. So one of the questions we then had, now we knew that we wanted to be able to find MODY patients better, how could we do it? And really the most important group to find it in was those patients thought to have type 1 diabetes, like the people in the first wedding photograph. And so what we found was that antibodies were very rarely found in MODY patients. Of course, in type 1 diabetes, depends how many you do, but close to diagnosis, it's going to be somewhere between 82 and 95%. And so this really gave the idea that using antibodies would be helpful. And particularly the other way around works extremely well. That if you have somebody diagnosed under 20, if you find antibodies, you can rule out MODY. The chances of that are just so vanishingly rare that you can really exclude it. And we actually were able to test this in a remarkable study done in Sweden, where they put every patient in the country for a 5-year period into a trial. And in every case, they measured the antibodies, and we were able to analyze hence the results from 4,000 patients. And what they found was that when you made no prior selection, that this was everybody diagnosed under the age of 18, that 12% would be negative for autoantibodies. And when you took those autoantibody positive patients, there were no cases of MODY in those. And we tested about another 200 to 300 people, and we didn't find any. In contrast, when we took patients from the antibody negative group, then we found that around 12% of those had MODYs. And so whilst the overall prevalence was only about 1.5%, we had moved to 12% by specifically ruling out the people who were antibody positive. And so that's really a very helpful thing. And I think for people working in pediatrics, you've really got a very simple policy. Test everybody with as many antibodies as you can. Most of us can't do insulin antibodies, but the key to do are IA2 and GAD, but there is advantages if you can do zinc transporter. And effectively, once you are antibody negative, if you tested everybody that was antibody negative, you would find about 1 in 10 would have MODY. But can you use clinical features to make it more likely? And what we found was at diagnosis, the key clinical features were things that went with a low blood glucose at diagnosis. So specifically not having symptoms of polyuria and polydipsia, having a lower glucose, and easiest to measure that with an HbA1c that typically in the MODY was around 7% against 10.2% in the type 1s. And then obviously a family history of diabetes was more common in the MODY patients, an absence of ketoacidosis, but that didn't rule out many patients because most patients in Sweden were not having ketoacidosis, only 12%. So really what we're able to say was that if somebody's antibody negative and they've either got an HbA1c less than 7.5% or an affected parent, then you will find 1 in 3 of those have MODY. So that becomes very efficient. Obviously, you can relax your criteria and take more. I just wouldn't relax the antibody one. So what about the adult doctors? So for the adult doctors, I think, again, if it's clinically, you think it's type 1 at diagnosis, do all the antibodies, as many as you can, but ideally 3 antibodies. And if those are negative, then I would definitely MODY test, especially if there was a parent with diabetes or the HbA1c was low at diagnosis. Deciding who to test also can be helped by the C-peptide, but obviously around diagnosis, a lot of type 1s have a lot of C-peptide, which then goes down as they come out of the honeymoon period. So a MODY random will typically have a non-fasting C-peptide of above 400 picomoles. So that can be used to pick them out, not at diagnosis, but later on. If they're clinically type 2, so you're not insulin treating them, then antibodies won't help you at all because your differential diagnosis is not with type 1. And really what you find is that factors like age of diagnosis, HbA1c, BMI, parental diabetes treatment can all help. And what Bev Shields did was to combine all these into a MODY calculator. And that really works extremely well in the patients where you're thinking about type 2 diabetes and provides a good discrimination to tell you which people you're likely to do. And the big advantage of the MODY calculator, which you can just Google and easily find, is it just puts in simple clinical characteristics. So everybody can use it. And so really, I think that's why stratification and precision approaches have been successful in MODY is because it matters for treatment and we can find ways of defining them. But really the key thing is that the subtypes are robustly defined by a genetic test. There's no overlap. We don't have people who are half glucokinase and half HNF1 alpha. You're one or the other. And there's a different cause for the diabetes that goes with the classification of subtype. And then what we've been able to show is this is clinically useful because of the different clinical course and the different treatment response. And I really will build on this idea of that's what you need for this kind of precision medicine approach. Now we're going to move on to neonatal diabetes, and really before 2004, if you were diagnosed very early in say at 6 weeks, like Elisa is here, with ketoacidosis, then there was uncertainty about whether this was type 1 diabetes or a separate thing called neonatal diabetes. And really it didn't matter, because if you had neonatal diabetes, whilst there were subtypes, sometimes it got better, sometimes it was permanent, sometimes there were other syndromic features, like you might lack a pancreas, but all of them were insulin treated. So in some ways, the definition didn't matter. But really, all of that changed when Anna Gloin found that the commonest cause of neonatal diabetes for people diagnosed in the first 6 months of life was a change in the potassium channel. And that change in the potassium channel was often a spontaneous mutation. So the parents weren't affected. It was just found in the child. And what Fran Ashcroft was able to show as a physiologist working on the potassium channel, that the mutation that Anna were finding was stopping the potassium channel for closing in the presence of ATP. And so the channel was there, all the insulin making machinery was there, but it wasn't able to release it because the door was closed. Well, you couldn't close the channel, which is what you needed to do in order to get insulin secreted. And a lot of good chance happened here. The first bit of good chance was that one of the patients had actually been referred from Brazil, and that patient had been treated with sulfonylureas for 46 years. And this had occurred because when he was diagnosed at 3 months of age, his parents, who lived in a rural area, were devastated because they couldn't afford the cost of the insulin. So they asked the pediatrician if there was any cheaper medication. And he said, well, we could try these sulfonylurea tablets, which were new at that time. And interestingly, he put them on sulfonylureas, and 46 years later, he was still on sulfonylureas. He was the only person not on insulin. He was the only patient we could measure C-peptide in, and he had the best glucose control of any of the patients. Interestingly, we were told he'd become a lawyer, and what that meant was he did have sufficient money. So when his 2 children were diagnosed in the first 3 months of life with diabetes, they both went on to insulin. So within one family with the same genetic cause, you had 2 patients treated with insulin and 1 treated with sulfonylureas. And so the big question was, could you stop the insulin? What this established was that at least some people could be treated with sulfonylureas. The big question was, could you stop the insulin treatment and replace it with sulfonylureas in his children? And then really came the next bit of luck. And the luck was that almost all the patients we had identified were under the age of 10. And in 5 countries, 5 patients around the world, with the permission of the patients, with the permission of the parents, they decided they wanted to try to see if sulfonylureas worked. And that happened in different ways, in different places. The best documented and the most careful was in Norway with Paul Nolstad. And what he did was to take his patient, and you can see in red that every 3 days, he increased the sulfonylurea dose very slightly. And after about a month, the insulin dose shown in yellow had halved. And yet the blood glucose shown in blue had actually got a bit better, if anything. And so this was really suggesting that the sulfonylureas were working, but we carried on, and ultimately the the sulfonylureas a month later reached a steady dose and the insulin stopped completely. And so we had patients who had been insulin dependent, presenting in ketoacidosis with no C-peptide, who were now treated with sulfonylureas. And that was because the drug was working in a very specific way in these patients. The remarkable thing was when we did a trial of 50 patients, one was that 90% of them were able to stop their insulin. And the other completely unexpected result was actually the HbA1c got better in every single case without any increase in hypoglycemia. And that was really unexpected. This is an example of it. You can see on an insulin pump, the glucose is high and variable. But once you give the glibenclamide, then you can see the blood glucose is lower, but also the fluctuations are going. And just this is actually in a 1-year-old child. The dose here is an adult dose of glibenclamide. And that was our other bit of luck, was that we were trying it in children and we were using doses which were about 3 times what you would normally expect to give based on body weight. And you needed those high doses because it was working in a different way. And I think the most remarkable thing was how that transformed life for the children and their parents, because they really now were insulin free. And it was really that they were free of the swings in their blood glucose. And that meant they didn't need to test at night. They could eat much more liberally. People were suddenly doing things which they couldn't do before because the teachers weren't happy. They could do school trips abroad. Parents were then happy for them to do sleepovers or play football in the school team. And so it really made a difference to people's lives. And the great thing is that that's still working now. So this is data 10 years later, a 10-year follow-up of that initial study with the same investigators from Exeter, from Norway, Italy, and France. And what we're able to see is the HbA1c is still excellent. The sulfonylurea dose, if anything, has reduced slightly in milligrams per kilogram per day, and 94% are still off insulin. And amazingly, with 750 years of follow-up, nobody has hypos with loss of consciousness or seizures in this group of children. So really, it has transformed the treatment of this type of diabetes. So what do you do when you found something like that? Well, what we decided to do was to offer free testing around the world to anybody diagnosed in the first 6 months of life. And knowing that around half of the cases were going to find a potassium channel and then would be able to come off insulin. And so far we've tested over 3,300 patients, and they've come from 117 different countries. And it's great now that we're getting increasing numbers from Africa and from countries where the cost of insulin and the availability of insulin really makes this a life-saving diagnosis. So that also meant that we were getting lots of patients, the other 50%, where the cause was not known. And so what Elisa DeFranco particularly has done is she set out to find new genes and understand more about what genes are involved in these patients. And she's done beautiful bits of work. And really where we are now is that there are 37 different genetic types of diabetes. And the majority of those have been discovered by Elisa in Exeter and some of the colleagues before her. But what we're moving is to a situation where we can find the cause of the diabetes in around 90% of patients. So we now have found so many more genes, and these genes are not only helping with treatment for the potassium channel, but also the ones who don't have pancreas, where there's exocrine treatment needed, but also identifying those with neurological features and other extrapancreatic phenotypes. And so this really is precision medicine based on finding the high blood glucose in the first 6 months of life. You move straight into genetic testing, and that tells you about clinical cause and about treatment. And so really, again, why has it been successful? It's been phenomenally successful in neonatal diabetes. This, because of the strength of pediatric diabetologists around the world, spread. So within 2 or 3 years, I think every case had been found. And if you ever find anybody in your clinic who was diagnosed with diabetes before 6 months, however old they are, please do refer them for genetic testing. Because it can make a big difference. We've had people as old as 58 discontinue insulin after 58 years on it. So it's really worth doing. But again, what we've got is these robust, genetically defined subtypes that you diagnose genetically, no overlap, different etiology, and that's allowed it to be clinically useful. So now we move to the more difficult part, which is type 2 diabetes. Type 2 diabetes is very variable, as shown by Anthony and Beryl here. And if you could predict the clinical course or the best treatment, it would be extremely helpful. And the main thing is that it's different from what we've heard about in monogenic, where we've got these clear genetic subtypes that are clinically useful. And the reason it's different is that you don't have discrete groups. You're using continuous clinical data to try and put your patients in. So for instance, BMI doesn't exist with one group of patients who are very thin and one group who are obese. There's actually an overlap between those different subtypes. And then there's not a clear etiology that goes differently if you use continuous clinical data to recognize it. And that makes it really, the question is there a clinical utility in identifying these subtypes? And that's, for me, that's what matters. We're not doing this because it's interestingly intellectually. We're doing it because we want to help patients. Firstly, could genetics help us? We know that type 2 diabetes is a very polygenic condition. I was involved in the very first genome-wide scan back in 2007. And those days, with only 1,000 cases and 2,500 controls, we could find 4 variants that predispose to type 2 diabetes. The latest studies are massive, more than 400,000 cases, more than 2 million controls, and they found 611 different loci. But the key thing is they're not discrete genetic subtypes, and they're really not clinically useful. So we can't use genetics at the moment in type 2 diabetes. What about clinical features? And there was a paper that got a massive amount of publicity in 2018, which used a cluster analysis and took the data-driven approach to try and identify 4 different subtypes of type 2 diabetes and also an autoimmune one, which was the equivalent of type 1. What you will see looking at these criteria, say you look at the BMI, is that whilst the BMI, the mean BMI differs, there's a lot of overlap in BMI between, and that's the typical thing, there's overlap between the different groups. It's also quite hard you have to have a whole group to work out the clusters. It's not easy, and they're not well defined, so that actually if you repeat it every year, people will move from one cluster to another. But in a way, that doesn't matter if it's actually improving clinical care, if it's predicting treatment response or outcome. And whilst they do predict it, they do not predict it as well as just using the clinical features. So if you want to know if someone is likely to require insulin, you can put them into a subtype, but you'd be much better just measuring their beta cell function on a fasting blood, and that would give you a better indication. So really, this is taking clinical features and making subtypes, and then saying for each subtype, there's different clinical course and treatment. But really, what John Dennis has done is come up with a different approach, really an outcome-based approach, which is to use the clinical features to make models of the outcomes that you want. And that might be clinical course, like time to go to insulin, or it might be the treatment response to a particular drug. And what John has done is develop this in routine clinical data and then validated it in individual data from clinical trials. So firstly, it may come a bit of a surprise to you that clinical features, we've never been taught, we never were told that some patients do a lot better with particular drugs. And just as a simple example here, if you look at routine data, you can see that if you're looking at the response to sulfonylureas shown in black or thiazolidinediones shown in red, that if you are obese, then the response to, rather than being not obese, the response to thiazolidines is much better in the obese patients, while the sulfonylureas do better in the slim patients. And then for sex, females do much better with sulfonylureas, whilst males do better, sorry, do that other way around. Males do better with sulfonylureas and females do better with thiazolidinediones. And because about half a male and half a female, and about half are obese and half are not obese, that means you can divide into 4 categories. And for this particular question of what is the best drug for lowering the sulfonylureas, you can see that there's a difference of as much as 5 millimoles per mole between the non-obese males and the obese females, with the non-obese males really being favored by taking a sulfonylurea and the obese females being favored by taking a thiazolidinedione. And you can do that in routine data, but then you can take it to clinical trials and look at how do the non-obese males do that are randomized to these 2 therapies. And you can see over the whole course, they do better on sulfonylureas. While the thiazolidinediones, by the time you get to 6 months, the thiazolidinediones are outperforming the sulfonylureas and continue to do that. So that really establishes that clinical factors can be helpful, and that's all based on data. But what about a trial? And so we decided to test the hypothesis that BMI altered the difference between pioglitazone and sitagliptin, and that renal function, this is within the normal range, altered the function of sitagliptin compared to canagliflozin. And the idea was that the obese patients do better on pioglitazone, and that those with less good renal function do better on sitagliptin. And so that was the hypothesis. To test it in a trial is quite tricky. What we did was a 3-way crossover study called the Trimaster trial, where you had each drug for 4 months, and then we measured the HbA1c at the end of that. And what we said was that what we found was that overall, the 3 drugs that people were randomized to had no difference in how much they altered the HbA1c. They all dropped it to a similar level. But when we did the particular hypothesis, we could see that your BMI, if your BMI was low, that favored, if non-obese, that favored sitagliptin. If your BMI was high, it favored pioglitazone. And for the renal function, if your renal function was lower in the normal range, that favored sitagliptin. If it was higher, that favored canagliflozin. But at this point, we're still using groups. We're still having fixed subtypes. And really what John was wanting to do was develop models. And actually that would mean that and what he was choosing to do was take the routine clinical features that were available on everyone and then model, for instance, the response to treatment A and treatment B, so he could work out who was the best for which drug. And really what we saw there was that you could then start to find clinical features, some that were defining patient subgroup, but a lot that were defining drug response. So SGLT2s work through the kidney, so the EGFR is something altering drug response, but not being really a part of a patient subgroup. And there are other things altering drug clearance. like some sulfonylureas are renally cleared. And so these factors would all alter treatment response, not just the factors that are patient specific. So this is outcome made models, and he could develop them in routine care and validate in clinical trials. And just probably the best example of this is one which asks the question, who blood glucose is lowered best on an SG2 inhibitor and who is lowered best in a GLP-1 receptor agonist. And what John did was create models, and then he was able to define the population that was spread between those in blue who do better on a GLP-1 and those in yellow who favor an SGLT2. And what was fascinating was that the women do an awful lot better on GLP-1s while the men do better on SGLT2s. And that was certainly something I had not been aware of when we went back to the trials. The trial evidence confirmed that the men did better on GLP-1s and the women did better on the SGLT2s. But what if you go to this paper, you can find a model where you put in the clinical characteristics and it predicts you which drug will be the best for your patient. And just to stop press, very excitingly and presented by John Dennis at the EASD, he's now produced a 5-drug model. And that 5-drug model will model all the different drugs and predict the likely treatment lowering for your patient. So you can then use that along with other factors in deciding the choice. And that's a very exciting thing, which potentially could be used throughout the world because it uses very simple clinical features. So really, to finish, MODY and neonatal diabetes are both causal and discrete, the subtypes. But in type 2 diabetes, we can't use the subtype approach because they're non-causal and overlapping. And so really what I suggest we do is we start to use algorithms. And another thing that I didn't talk about here is the other thing you can do is let the patient decide by letting them choose between the different treatments. It just leaves me to thank everybody in the Exeter team. We've been working for nearly 30 years together, and many of us are still there, and it's just been an enormous pleasure. So thank you very much.
Thank you so much, Professor. I'll be asking for Milena to open his camera.
It's already there. It's already open. Yeah, thank you, Professor, for a wonderful talk. Like this whole journey, historical, interesting journey about genetics in diabetes. So I have 2 questions. The first one is regarding MODY calculator. Is there any news about the new version with C-peptide and antibodies? Because I've heard not this. Last year in Germany, last European meeting, I've heard some people from your team just saying that it might have a new version. So I'm just eager to know if there's any news about it.
Exactly. It is developed. We're trying to persuade Bev to release it out into the, but it is going for publication very soon. And the key thing is it works much better in the type 1s because of the antibodies.
Perfect. And I just wonder, what's your view? Like we know that genetic testing is so much less expensive nowadays. So regarding all the genetics that we now know that we might find if we do the test, where do you stand about asking, ordering just panels, like genetic panels, or the whole, I don't know, exome or even genome, if we have the polygenic risk scores? Do you think it's worth it to go directly, like maybe in a few years, or do you think it's already the time to go a little bit like more broader?
Yeah. I still think for the patient and for the doctor, there's a level of testing which you start to not want to do it. I would be reluctant to ever go below 10%, of getting one positive result back for everyone you sent off. But I think one thing we're doing is practicing for when it gets even cheaper. And technology will just get cheaper. So there will come a time when people do get genome sequencing at birth, and I don't know, or as an adult, I don't know if it will be in my lifetime or not, but it will happen, and we're going to have to learn before that happens. So I think that's what we're doing, is learning before it gets cheaper. I think what we are doing now is, because it's cheapest to do an exome, we will do an exome because it's cheap, and then we can just put a screen on it so that we can choose the gene. We only look at those genes. We don't look at the rest, because that leads to disaster. So we just look at the genes that we would look at, but because exomes are done commercially and easily, it makes it easier, because then it's one way of processing in the lab every sample. Sean was very good at making sure we were practical on the lab side.
Good. Thank you.
Thank you. Nós temos pergunta na plateia. Então, eu vou passar a palavra para a professora Berenice.
Good morning, everyone. Professor Andrew, you are a legend of endocrinology, and you are so proud to have you here. And I would like to let you know how important you are for our diabetes group, and mainly for Milena. We actually improve our way to study diabetic patients. And so I am very grateful to have you here. And also I admire you for a long time and in your presentation and about your job. And I would like you to tell some words, what move you, and some words for the young endocrinologists, because some of them think that everything is done. And when we see your career and what you did, is so many people are helpful with your work, and you are still working. So I would like to show us what move you and what you advise our young endocrinologists. And thank you very much for coming.
Those are very, very kind words. Thank you. It means a lot. What I would say is that it's interesting that people always think where they are now is the end, and I remember when we found the genes in 1996 for HNF1 alpha and or Graham Bell did, then by a meeting we had of geneticists even in 2000, the geneticists were saying monogenic diabetes is over. We found the main causes, it's all finished. And it was interesting because I had chosen to go in 1995 to Exeter, which wasn't a major center. And I think one of the things I would say to every young endocrinologist is it matters who you work with, not where you are working. Don't be hung up on it's Harvard, it's Cambridge, it's Oxford. Care about the people that you are with, because that's what made the difference. And you need people with different skills. What we had was Sian Ellard, a brilliant scientist. She'd come as a postdoc from Swansea, not a major university, in cancer, but she had vision and she wanted to set up a human lab. And actually, that was brilliant. And then we had Maggie Shepherd, who was a nurse. And what she did was to bring the patient's viewpoint into it, to understand that not only the patient, but the doctors didn't understand genetics. So stop talking about it, get on and explain it. And then we had Tim Frayling, our very first PhD student, who wanted to understand type 2 diabetes and did the genetics of that. And I think it was those people coming together, because we had one thing that we all wanted, was we wanted to enjoy ourselves when we went into work. And I think that really, really matters, the atmosphere in your team. And if it's a clinical team or a research team, work on that, because that's what will make, if they say, if you love your job, then you don't really get work, and I feel like that, I get paid for doing things I love. So I'm really lucky. and never let anybody tell you a field is finished. We wouldn't have done neonatal diabetes, we wouldn't have done HNF1 beta if we'd listened to everybody else.
Thank you, Professor. We have one question from the online people. Is Professor Ivo? He was my supervisor. And he asked, could you comment if outliers in the type 2 diabetes polygenic score can direct further genetic testing?
Yeah, that's a fantastic question. And if you get a chance to look at the EASD, there was a talk presented there. The senior author is Kash Patel, about this thing. So the two things, so one of the things we hadn't realized was, what about the polygenic component in MODY? So the first thing that they showed was that there's a lot of genetic modifiers. So the people that we see young actually not only have the gene, but also have a polygenic load. But what was really exciting was when they looked at people where we hadn't found a cause in our MODY cohort, that they had a type 2 genetic risk score that was double. So that, and actually what I've suggested we might call this is double dose diabetes. And that term was used before when people had two parents with type 2 diabetes and were then getting a beta cell disorder early. So I think they're not like MODY because they don't have that clinical predictability because there's multiple etiologies. But those extremes of the scores, I think that is going to be really useful. And actually that once we can start to put the two together, I mean, that's why I say it's not finished. You think monogenic is over, Milena, the next thing you will definitely be doing is polygenic risk scores on top. And I think as a research project, if you can get some things done on your patients and also your null patients, there will be interesting things to find. But and what we have found is when the technology changes, what you can do in research changes. So that's another general point. So now it's very easy to get all the polygenic markers. We can get it for $25, you know, for all of the common variation on one person. So it's...
Yeah, we do have a student right now. He's in here, Augusto Santomar. He was with me in Exeter. He's doing polygenic risk score, type 2 risk score in lipodystrophy patients. I mean, for to begin with, yeah.
Yeah, so once he's done that, then he should do the partition score for lipodystrophy and see, because that's what we found was that the partition score for beta cells was the bit that was modifying the type 2 from the type 2 risk.
Good.
So
Thank you.
Do get him to get in touch. We would be very happy to talk.
Good.
So, Professor, before we close, I would like to tell you that our head of the department, Ana Cláudia Latrônico, sent you a message, and she says, excellent talk. Iconic scientist who transformed the diagnosis and treatment of diabetes mellitus. Thank you very much. And she's in the top, and there's a lot of people, if you can have a look in the chat, that thank you very much for your presence here and for your great talk. So at this point, I also say for you, thank you so much. And I was very touched when you talked about the team that you had. So you become, you bring together scientists and the clinicians. So I think to do what you've done, it's very smart to bring both because each one give their contribution. So I think that this is some kind of a counselor to the ones that are beginning. Thank you so much. And do you want to give any comment, Professor? Because I'd
just like to say thank you from the bottom of my heart. I'm very touched by your kind comments. Thank you.
Thank you so much, Professor. Have a good day. And we are very happy that you've been here with us. Goodbye.
Goodbye. It's been a pleasure. Thank you.